Good morning, everybody. My name is James Lutowski. I'm a paramedic in the city of Pittsburgh, and I'm here to invite you to the new generation of my podcast, Prehospital Case Study of Grandeur. About 5 or 6 years ago, I had a podcast website where I posted a video with a case study or some type of interesting pre-hospital thing about every month almost. And we had about 1,000 views a month. That was really great. I shared a lot of good information and got a lot of good feedback. But over about a year and a half that I was doing it, I got very busy. Eventually, kind of slacked off at posting any videos, and then eventually let the website go defunct, and it kind of went by the wayside as I was doing a lot of other things. Over the past couple of years, I've learned so many things. I've taught a lot of places, and I've had a lot of good experiences. So I've decided to regenerate the podcast and try to share with you whenever at least I experience something interesting or new that would be a good learning tool. So I would like to give a quick shameless plug out to one of the best online educators I know. It's Dr. Amal Mattu from the University of Maryland Emergency Medicine Program. I put the EKG video of the week up weekly, obviously, and he does a really good job, even for pre-hospital people who don't have advanced training. When a lot of his followers, I would say, are probably residents, fellows, medical students, but I'm sure he has a large pre-hospital following. But it that all I'm saying about that is it's not over our head. A lot of times, if you go to an advanced EKG conference, a lot of it is described in terms that it's hard to understand. So his videos are actually very easy. They're very easy to watch. They're usually under 20 minutes and they're extremely educational. So I would say go to this, follow them, and spend your days learning about EKGs. So he does it weekly. And if you really like EKGs, they go back all the way to 2011, one for every week. So you could probably get a lot of EKG knowledge to catch up on too. So there it is. Go there, watch his videos, and learn many things about EKGs right here. And I think you'll really enjoy it if you like learning new things and you like learning EKGs. So for this video, since a lot of you probably, hopefully some of you were my followers from before, but I'm sure a lot of you, this is the first time hearing about me, some guy from Pittsburgh. So I'm going to tell you a little bit about myself and where I'm from. So this video is going to be a little bit longer than the ones in the future. And at the very end of the video, I really would like you, I'm going to have a calling for your EKGs, and I really would appreciate if you would stay to the end and watch the very end of it about me needing your EKGs. But I'll wait until the end, so if you don't want to watch that, you don't really have to. So obviously, my name is James. I'm from Pittsburgh, Pennsylvania. I went to North Hills High School, where when I was 16, I went to EMT class, and then I moved to Alaska actually after high school. And I went to the University of Alaska Fairbanks for my undergraduate, and during the nighttime, I took my paramedic program. So obviously, this is a really cool place, amazing. I love winter, I love the outdoors. So this was an extremely good opportunity for me to go experience a place, live there during college, and then come back and bring with me what I learned. So this is Alaska. Great program, actually. If you're looking for an emergency services program, either in fire or EMS, UAF is something to consider. If you want something that's outside the box, very good institution. The paramedic school is excellent. Their fire science academy is very good. So if you are looking for something to try that almost nobody else has tried, I would suggest looking into the University of Alaska Fairbanks and their emergency services program. You can get that on uaf.edu, and you can get all the information, or you can email me, which will be at the end of this video. My email will be there. You can always email me and ask me anything you want. So when I moved back to Pittsburgh, obviously where I am now, I started here at Northwest EMS, and it's kind of a private, community-based 911 service that does enter facilities. Shortly thereafter, I started volunteering with Ingram EMS, which is actually where I am now. We've had an extremely busy night. We're all volunteer. I'm the assistant chief here. And extremely busy. We had one transformer explosion that we stood by for at about 8 o'clock last night. So, extremely busy. Here is, over here, we see the ambulance from Chena Goldstream Fire and Rescue, which is one of the fire departments in the Fairbanks North Star Borough. And I volunteered there while I was in college. And of course, right before I got hired at the city of Pittsburgh, I worked for Harmony EMS as a paramedic supervisor. So I left there only because I got this extremely awesome job at Pittsburgh EMS. If you can look at any of these pictures and not think that this is not the coolest job in the world, if you can look at these pictures and say this is not the place to be, then you should probably just hang it up and go be a hermit somewhere, because not only is Pittsburgh extremely awesome, but Pittsburgh EMS provides every rescue service, including technical, vehicle, river, everything you can imagine, high angle, low angle, as well as all of the 911 ambulance services for the city of Pittsburgh and Mount Oliver Borough. So, if you're looking for a really cool place to work and get a lot of good experience while making decent wages and having an excellent time with amazing people, you should go to the City of Pittsburgh website right now, push pause, go there, put in an interest card. You'll be notified whenever applications are open for paramedics, and then you should apply immediately. So go ahead and pause, go there right now, put in your interest card. I know you want to work here. This is an amazing place to be, it's an amazing place to live, and it's an amazing place to work. So feel free to ask me any questions you want, but this is the place to be. Come on down. So, without any further ado, I believe we're going to get to the case. And so, this is what I'm going to give you at first. We're dispatched to a 54-year-old male who is unconscious. So, that could be anything, anywhere from a cardiac arrest to an intoxicated person, someone who has a victim of a homicide. It could be a person who had fallen asleep. It could be a 90-year-old in reality and someone got a mistake. It's very hard to know. So that's all that you know that you're responding to. So you get to the scene. It's about 2:30 in the morning, and the patient is awake, but he's not responding that great. And if you don't try to wake him up, if you're not talking to him or actively doing something to him, he kind of falls asleep on you. So immediately he could be anything, diabetic or what have you. He answers the questions, but it's difficulty to get the answers out, and he's so tired that he's kind of falling asleep while he's talking to you. He complains of weakness, nausea, nausea without any vomiting. He's having some trouble breathing, and he has chest pressure, which is non-radiating, retrosternal, non-reproducible. He looks terrible. He's very sweaty. He's very ashen. Um, he has a little bit of labored breathing, mostly tachypnea. He doesn't have accessory muscles, but you can see down here on the exam, he has some diffuse crackles. So that, of course, is not the best. So uh, he smells a little bit like alcohol. His wife is there. You get the history as best you can. He has multiple alcohol bottles around him. And he has a history of chronic alcoholism. He's been an alcoholic for about 30 years. And his wife, she just has come to accept it, and he's having trouble breaking this cycle. He also has a history of atrial fibrillation, MI, times one with 2 stents placed a couple of years ago, and a history of hypertension. His medications are Coumadin, lisinopril, HCTZ, spironolactone, aspirin, and amiodarone for his AFib. So you go and you reach down and you feel his radial pulse, and you don't really feel anything. So you go up to the brachial, there's nothing there. You feel the carotid, and it is very, very, very weak, and it is extremely irregular. Now you might notice that here I put irregular squared. So what could that possibly mean? It was actually a very strange pulse when I felt it. His not only was the timing of it extremely irregularly irregular, if you will, but also the intensity of the pulse was irregular. So you might call it thready. We were unable to get any blood pressure by any means. We put the monitor on and we got nothing but question marks, and we tried auscultating, and obviously we tried palpating, but there's no pulses. So no blood pressure available. His respiratory rate's about 32, just a little bit labored, and he's 87% on room air. He has JVD, diffuse crackles, normal heart sounds, and no edema that you can see. So what are some of the immediate potentials? You could think congestive heart failure, etc., but those would likely, if his heart rate is too fast to count, extremely weak and irregular, maybe these additional symptoms are the result of the underlying cause. Now, you get this heart rate that's too fast to count. You can't get a good number on the pulse ox, and the monitor is being applied by your partner as we speak. Um, it immediately ticks you to AFib. right? So he could be in a rapid AFib. It's very fast. It's very irregular. He has a history of AFib. So that's my immediate thought, is this person is in an unstable rapid atrial fibrillation. So my partner's getting the monitor on here, and it's about 2:33. So we've only been there a few minutes, and we got a few things done. Putting the monitor on, and immediately as that last lead touches the skin, the monitor starts squealing at you like a pig at the parade. It is just going off. You turn around and look, expecting to see the person that is in rapid atrial fibrillation, but instead you see torsades. Nobody's ever in torsades anymore. It is the classic case of torsades. You can clearly see the polymorphic tachycardia. You can see very smooth transitions, okay? There's not really a lot that stick out, which is kind of like a, to look for if you're debating whether it's torsades or VFib or artifact. You are kind of looking for, if it's like this, but then there's suddenly, there's just not a smooth transition. Some are lower, some are higher, kind of jutting out there. So, excuse me. Okay, sorry about that. So you can see that these transitions are all pretty smooth. There's not really any that are sticking out way high or way low compared to the other ones. And it is a classic spiraling effect that you would see with torsades. So this is a pretty clear case of what you would say as a polymorphic tachycardia, that is torsades. So suddenly the Jekyll and Hyde in me comes out, because on one hand you're very concerned about this patient and something terrible could be happening to him and it could get worse at any second, although it's pretty bad already. But then the other side of me, who's been having a love affair with emergency medicine for the last 12 years, is extremely excited, because how often do you see a torsades? I can tell you that I've had one case when I was in paramedic school at Fairbanks Memorial Hospital that I was lucky enough to be in the emergency room to see when it came in. There was a case of a dialysis cardiac arrest when I worked at Northwest EMS. And then earlier this year, I guess late last year, I had a case with the city of Pittsburgh, which was kind of similar to what this case is going to end up. So very terrified for the patient, but also excited at the same time, because this is something that doesn't happen every day. So you get the EKG on while you're trying to get the vital signs. My partner's doing the 12 lead. I'm trying to work on access. We're getting the defib pads on him. And the 12 lead's not the greatest, okay? So you're trying to see, you can kind of see a little bit here. You have this curvature. Let's see if I can get my pen here. You have this kind of swing, and as you probably know, that these are continuous. So 1, 2, and 3, AVR, AVL, and AVF, V1, V2, and V3, V4, V5, and V6. Those pictures in these lines are taken 3 at a time. So if you read across, generally, this is a long rhythm strip. It's just different leads. So if you see something in one lead, like if, let's say there's a PVC here, but there's not a PVC here, and there's not a PVC here, then that PVC is likely artifact, because these 3 pictures are taken at the same moment. These 3 pictures are taken at the same moment, etc. So if you follow this around, you can kind of see that same classic turning, but the amplitude's kind of low. I think the monitor was just trying to fit all this on at once. But you can kind of see it's pretty smooth, not a lot of jutting. You can see up here, I think the amplitude's much higher, but they're like cut off at the top. Probably because the monitor was trying to keep the actual complex is small enough to get enough onto the screen. So that's one of the downfalls of pre-hospital 12-lead EKGs. So I'm going to take a quick second. Those of you who used to watch my podcast remember Bertram the Bookworm. Bertram the Bookworm is who I imagine to be sitting inside the monitor, and he is the one who rings the alarms and tries to interpret your EKGs for you. So here's Bertram. He's working very hard, and now he's finally come up with an answer, and it is nothing. So Bertram did not really pass the test on this one, but thanks for your try, Bertram. So after the EKG's on, I'm working on access, still no pressure, so we're opting that we're probably going to cardiovert this person in short order. My partner hits the 12 lead EKG button again just to see, and this one's actually a little better. So you can kind of see this torsades turning of the points, giving you this spiraling kind of thing. So it's pretty clearly torsades. Bertram's down there working hard. Bertram, what did you come up with? And it is AFib, A flutter with a, non-specific intraventricular conduction delay. I don't think so, Bertram, but thank you again, my friend. You're always there trying your hardest. So that's about 2:36 in the morning. We've been on scene for about five. It probably took us a couple, a minute or two to walk upstairs. So we've been on scene about 4 minutes, I'd say. But we walked in the door at 2:32. So let's talk about torsades for a second because that is what we have figured this out to be. So the patient's in torsades. So some of the causes of torsades you think about is prolonged QT syndrome, whether it is genetic or if it is acquired or new or acute or whatever you want to call it. Could be Brugada syndrome, causes some life-threatening tachycardias. Electrolyte imbalance could definitely cause that, whether it's magnesium, calcium, or potassium, which medications can affect your electrolytes. Dialysis certainly can uh, affect your electrolytes. And dialysis doesn't necessarily affect the electrolyte imbalance, but dialysis certainly could cause it if you don't go to dialysis when you're supposed to. But it's really the underlying kidney disease that would cause the electrolyte imbalance. Malnutrition or eating disorders can cause an electrolyte imbalance. Medication toxicity by itself without electrolyte impairment could certainly either prolong the QT interval or increase your potassium level. You could have stress-induced cardiomyopathy. It's really hard to tell in the field. Hypothyroidism to this extreme, I don't know. Hypothermia can cause a lot of unstable rhythms. That's why that's in there. And STEMI is not necessarily a common causer of uh, torsades, but STEMI is a common cause of life-threatening dysrhythmias that cause sudden cardiac arrest. So, how do we know that 10,000 of the 300,000 people a year that suddenly die of a cardiac event were not in torsades as their initial rhythm? Well, nobody knows because a lot of those 300,000 people are either found dead and are never put on the monitor, or by the time paramedics arrive, they're in asystole or PEA. So it's really hard to say what an initial rhythm is. We can only go off by what we witness. So that is why the asystoles of the world are the highest for pre-hospital cardiac arrests. So what can we rule out here? The patient is not very cold. So we can go ahead with the hypothermia. Hypothyroidism, he doesn't really have a history of it, but he is an alcoholic and maybe hasn't been to the doctor in a long time and maybe hasn't, but he's been taking his medications appropriately. So you want to cross off medication or medication toxicity, right? Because he says he's been taking them appropriately. So we'll think about that later. Could be, it's probably not hypothyroidism. He has no history of that. This one's too hard to say, so we're just going to put a little check there. It's hard to tell. Now, malnutrition or an eating disorder is an important one because a lot of times, as you know, chronic alcoholics won't eat correctly, and you could develop electrolyte imbalance, and sometimes they require thiamine, magnesium, or what have you. He's not on any dialysis, so he has no history of kidney disease. And this one, it's too hard to say. All we can say right now is that he takes his medications as prescribed. Now, Brugada syndrome, in this case, we can't check it off or cross it off, right? Because we can't see his EKG findings when he's in a normal rhythm at this time. So how do we know that he doesn't have Brugada syndrome? Well, it's a congenital syndrome. He has a history of an MI. He's had to have had multiple EKGs in the past, and Brugada doesn't just show up when you're 54 years old. When a couple of years ago he had an MI with multiple EKGs performed, so you would have to assume, even though you have never seen his EKG and you don't have access to them right now, that Brugada syndrome in this 50-year-old male who's had a cardiac history and sees a cardiologist, he does not have Brugada syndrome. So you're kind of left with this little bit of diagnosis that you're not able to count out right now is the prolonged QT, An electrolyte imbalance, what is it caused by? It's hard to say. Um, this one's kind of, can't really say that at this point. And STEMI causing a life-threatening arrhythmia could always be the case when you're in a wide complex tachycardia or a VFib. So let's go on here. So what is the treatment course? So immediately you think you have an unstable tachycardia, the patient has no blood pressure, he's gray and sweaty, he's having chest pain and shortness of breath, you have to cardiovert them. So the problem with torsades is without treating the underlying cause, torsades recurs in almost every single patient. So if this patient has hypomagnesemia, um, oftentimes the torsades comes and goes in bursts and then reverts back to their intrinsic rhythm by themselves. And it actually just needs medication. As you can see from that EKG, it was a very long strip, and he was pretty stable in the torsades. At least the rhythm itself was staying the same. He wasn't in and out of it. So this, I had a feeling that it would be more likely that in this case, even though cardioversion is not the top choice for torsades, I felt like that in this case it would be more effective because his rhythm was staying the same. So we did cardiovert him at about 238. We gave him 150 joules, and like I said, if the patient's not staying in the dysrhythmia and he doesn't have signs of hypoperfusion, then perhaps you would move on to a medical, um, less invasive, like giving a medication such as magnesium. So we did that as well. Um, and here's just the reason, the reasons that he's clearly shocky and you can't get a blood pressure. He doesn't have any pulses at this time, but he is awake, so we know that he's alive. But even the carotid pulse was lost by this point. And we could not get an IV. I could not get an IV to save my life. So we were getting ready to do an IO. But we ended up getting an EJ. As I said before, he had some JVD. We put a 16 gauge in his EJ, started him on 2 grams of mag, and the cardioversion was effective. It took him out of the torsades, and the torsades for us never recurred. Um, so as I'm doing all this other stuff, I'm doing the IV, getting it taped down. We had cardioverted him, confirmed there was pulses, a little bit slow, um, and so we start moving on. I'm getting the medication ready, and my partner hears, he says, "You better look at this." Just then, the monitor starts to ding like crazy. And I look over at this screen, and we run this strip. So immediately you think, what the heck is going on here, right? So if you just take a quick gander, what rhythm is this? So is it a ventricular rhythm? I don't know. Is it a sinus rhythm? You have these weird blips every once in a while, but they're not up here, so that probably might not have actually happened. Some of these morphologies in here are different for every one. So there's potential that there's P waves buried in there. Is this here the QRS? So you're trying to decide if that's the QRS and these things are the T waves, or if this is some type of weird presentation of a very wide bundle branch block. So we go ahead and do a 12-lead EKG, and we're preparing to potentially start pacing the patient. Now, there's something that you have to think about whenever you see these really, really wide, complex rhythms, especially at a tachycardic or bradycardic rate, and it's usually potassium. Potassium is the first thing I thought of when I saw this EKG. So we run the EKG. Old Bertram here comes up and he says, "Oh, let me help you here." So he's going to help us figure out what the rhythm is. You look in V1, which is one of the best places to look for P waves, and there's only one complex per, in V1. So is this a P wave here? It's hard to say. Is it in here somewhere? I don't know. So we can't really firmly call this a sinus rhythm at this time. What you can call it is very wide, extremely bizarre, and kind of sine wavy, right? It's kind of sine wavy like that if everybody remembers math. And they tell you sine waves are common in hyperkalemia patients, right? So let's see what Bertram has to say about this EKG. No further analysis attempted. Okay, thanks, Bertram, for your try. I guess he just did not want to participate in this one. All right, thanks. And the Q restoration, clearly, I mean, one of the reasons that I put the machine analysis in is just so you can see that sometimes, and more often than not, they say the wrong thing. So even here, the heart rate's 113, right? it clearly is not 113. It's about 40. If you do the check boxes, it might be even slower than that in this EKG. And clearly, the QRS duration is not 102. So let's talk about the differentials for wide QRS bradycardia. So, is it a ventricular rhythm? We're just going to jump down to there. That one we cannot rule out, so we're going to leave it, right? Toxicity, he doesn't take any tricyclic antidepressants. He's been taking his medications as appropriately. He's not suicidal, and he doesn't have any other exposure to anything. So toxicity, you want to cross off. Could it be a STEMI in the presence of a conduction delay? So we'll go back here. There's definitely some ST elevation. You know, if this is in fact the T wave, there definitely could be ST elevation there. And these could be T wave depressions and inversion. If this is in fact the J point, it would actually be more like right there. If those are the J points, then this is definitely below the baseline. So could this be an inferior wall MI? Sure. It's really hard for us to say right now, but the gut tells you it could be hyperkalemia, right? So we are going to say possibly a ventricular rhythm. You could say possibly STEMI in the presence of some type of weird conduction delay. Is it toxicity? You want to say no. WPW, he has that cardiac history, and so you think that would have been found by now. Right now, you can't really diagnose that. The non-specific conduction delay, it's extremely doubtful. Is it a bundle branch block bradycardia? It is so wide that you want to say it is not a bundle branch block. It doesn't have any of the normal findings for a regular bundle branch block. Could it be hypothyroidism? Well, he doesn't really have a history, and like I said before, hypothermia is not really a case. He's inside in a warm home. His wife is fine. He wasn't outside. He's wearing clothes. He's not soaking wet. So hypothermia is likely not the case. So we're left with hyperkalemia. So that one's left for us here. So this is what your gut tells you. These are some of the possibilities that are left that you can't rule in or rule out. So it's time to make some decisions. You call medical command, you send EKGs, and first you have to identify what you think the underlying cause is, and then decide how you're going to treat that cause. Are you going to start the pacemaker? Are you going to give medications? Is he hypothermic? You're going to rewarm him. So a couple of these we're going to cross off, right? So we're not going to rewarm him. He's not in a sinus rhythm, so this likely isn't going to help us. Are you going to start him on dopamine or epi drips to try to increase his contractility? That's certainly a possibility. But if you're thinking that it is a bradycardia as a result of hyperkalemia, this is the one that we're thinking. So this is the order that we're going to call for and discuss with the physician is the calcium. And right now we're going to put this, we're prepared to do it and it is ready to go, but we're consulting with the physician to decide what to do. Okay, so our treatment plan discussed with the physician was to give an amp of calcium chloride, 1 gram IV push, over a couple of minutes. We gave albuterol nebulized over time, 10 milligrams, 50 milliequivalent amp of sodium bicarbonate. We repeated the EKG and vital signs, and IV fluid bolus of about 20 milliliters per kilogram was started. So at this time, the pulse is about 40. His BP is obtainable, which is great because it wasn't obtainable before. It's about 60. But when you're listening to it, there's no radial pulses, no brachial pulses, but you can hear the brachial sounds. And as you hear your first confirmed sound at 60, and it goes all the way down to 0, which is better than not being able to hear anything, still not the best. Respiratory rate's about the same. On a non-rebreather, he's about 94%, and his glucose is 204. So you started the treatment, and now we're praying that we're going in the right direction. So now we look at the EKG about 5 minutes later, and it definitely has a different morphology, right? So we take a quick peek at this EKG, and it looks narrower. The rate, so the QRSs are narrower. The rate has actually picked up some, and you're getting a little bit of definition. Okay, so if you're looking up here at the top one, these here are kind of weird looking, and down here these morphologies are different. So could there potentially be P waves buried in this very bizarre wide rhythm? Potentially. However, if you look at the top, there's not really a lot of evidence to support that there's any P waves in here at all. So we're going to go ahead and still not call this a sinus rhythm, but we're going to repeat an EKG and see what Bertram has to say. So we look at our EKG and it looks much better. You have a little bit of definition here. Let me get my pen up. So we have a little bit of definition. There's the potential that this could be a P, and it's repeated in every lead here. So maybe that's a P. There's also some evidence of maybe something's in there. This could be something over here. What are these? Are these the T waves? And this is the QRS. So there's a lot of questions that are still to be answered by these EKGs. What you can tell is you're making progress. Now, one thing you can look at in this here is gone. This incredibly bizarre, potentially STEMI-esque T waves in the inferior leads are no longer there. So while we can't rule out a STEMI completely, what we can say is that our index of suspicion for STEMI is now lower, and our index of suspicion for hyperkalemia is much higher because we're giving medications for hyperkalemia, and the treatment is actually giving us some results. So Bertram, what do you have to say about this? Sinus tachycardia at a rate of 100. Okay, thank you for your service. I'm not even going to read the rest of it. All right, next. So we reconsulted and retransmitted the EKGs. We've already decided that we're going in the right direction by giving the hyperkalemic style treatment. So he wants a half of a gram of calcium chloride, continue with the continuous albuterol, support the pressure mostly with fluids and treating the hyperkalemia. And the vital signs are better. The pulse is about 50, 72 over 30. The respiratory rate's 36, and the SpO2 is 96% on high flow oxygen. It's time to start moving the man. We're going in the right direction. He's more alert. So we get him into the Reeves and we carry him down to the ambulance where we do a reevaluation, which looks much better. By the time we get to the ambulance, you can see that we have clearly defined QRSs here that aren't that extremely wide. Um, there's no P waves that you can see, but the rhythm is irregular. It appears that he's in AFib, and he's been in AFib for a long time. He has a history of AFib. So there's the potential that this is his baseline rhythm. Maybe it's a little wide for him, but we do an EKG just to take a gander, and he's clearly in AFib, still having abnormal T's all over the place. A lot of the places T waves are almost non-existent. So we're looking at the atrial fibrillation here, and the QRS duration and the QT intervals are not as bad. The QT is a little hard to discern, obviously, because we can't see the T waves very well. But here, Bertram might help us out, so we're going to take a peek here. The heart rate's about right. He's about 120 to 140. Atrial fibrillation, so we got that. Thank you very much, Bertram. The intralateral infarct is certainly possible, but by this EKG, I think we should give it a little bit of time to get back to his baseline, keep treating him with the calcium, let those medications work, and then compare his EKG to the old EKG that they have on the computer at the hospital. So we got there at about 2:30 in the morning. It's 3:10 in the morning. We're on our way to the emergency room. So we arrive at the hospital at 3:15. He's awake and alert, but looks really beat. His skin is not diaphoretic anymore. It's not sweating. Before the sweat was dripping off of his face. Now he's not really having that, but he is pale. His chest pain and shortness of breath are gone, but he feels very weak, very nauseated, and he's exhausted. His vital signs, his pulse about 110 to 130 now, atrial fibrillation, good blood pressure without any inotropes, 108 over 56. The respiratory rate's about 20 and non-labored, but remains with diffuse crackles. So you guys can read. I'm not going to read everything. He's about 97% on a non-rebreather, and we did a repeat glucose just to be on the safe side. It's 219. And we did that because we got a second IV in him as his pressure came up. He had more venous access. We put in a second line. We had the ability to check a quick glucose that was convenient. We did so, and it was still pretty good. He has no history of diabetes or kidney problems. So who knows why he's a little bit hyperglycemic here. So let's talk about the hospital treatment course. And this is going to tie in with how we figured out our differential diagnosis, and then we're going to try to find out what the root cause of his hyperkalemia was. So his serum potassium was 8.7, the first blood draw at the emergency department. So his serum potassium after 2 doses of calcium and all that albuterol and the sodium bicarb is 8.7. Now, I should mention that sodium bicarb's kind of fallen out of the wayside for initial treatment of the hyperkalemia. However, uh, in the in the presence of acidosis, you would still give the sodium bicarb. And the physician and I discussed it, and we decided that with this EKG finding, his potassium is probably skyrocketing, and that he would likely benefit from the sodium bicarbonate because he's probably acidotic. So if you think you gave 2 doses of calcium and the albuterol and the sodium bicarb, and you had all those EKG changes, so you're pretty confident that that's the cause of what everything was happening was the hyperkalemia. But the serum potassium is still 8.7. So imagine what his serum potassium would have been before you did that treatment. If you could have done a point of care at the scene, it could have been much higher than 8.7. So they also did a serum magnesium because he was in torsades, and it was 2.6 after the administration of the magnesium, which is actually a little bit above normal. And the physician started to think at the emergency department that maybe he was not hypomagnesiemic from, and the magnesium might not have actually done anything for him. That perhaps the torsades was caused by the extremely wide cuirass. So usually torsades is found in hypokalemia, so it's very odd, but it's always possible that he had low magnesium as well, and we gave him, the 2 grams of magnesium, and it just really improved his magnesium level. But they seem to think at the hospital that his magnesium level wouldn't have climbed that high from being low enough to cause torsades to over the accepted normal value. So he did have a slightly positive troponin at 0.05. The next one was 0.11, and I think it was 0.09 for them, maybe zero point 0.1 is the point where you decide that person has a positive troponin and should consider catheterization or the suspicion of cardiac damage. His next serial troponin, however, gave it to 0.04. Within 48 hours, he didn't have any positive troponin. And they did a stat echo at the emergency room just in case. They didn't see any decreased wall motion, so it appeared like he was not actually having a STEMI. This rhythm was likely the cause of the hyperkalemia in and of itself. So they continued the treatment in the emergency department, calcium, insulin, dextrose, and albuterol. The bonus question is, what is the mechanism of the albuterol for people who are hyperkalemic? What does the albuterol do to decrease the serum potassium level? I'm not going to tell you that answer, but I'd like you to figure it out and let me know what you think. He was admitted to the ICU where he spent several days before he went to a step down. He did suffer one subsequent episode of uh, ventricular tachycardia. It was not torsades, it was a monomorphic VTAC. He was treated with medication, and he came out of it and was put in the step down unit almost a week later and discharged to home, about 5 days after that. So let's talk about the root cause of the hyperkalemia and both of the near fatal rhythms he was in: an extreme bradycardia with hypoperfusion and torsades with hypoperfusion. So we're going to talk about the importance of doing the HPI, the standard history exam, the interviews. They're all very imperative to figure out what is wrong with any patient, not just this one. It's important that even when you think you have the answer, that you do a good HPI instead of just thinking that you have the answer, because then you might miss something, or you might miss something that is concurrently happening with what you think it is. And that happens more often than we think in medicine, where there are 2 things happening at once. We like to blame one thing on the other and say it's completely related, but it could just be coincidence that it happened at that time. So and I think the next case I'm going to post, which I don't know how long that's going to be, the next case I'm going to post kind of has a similar approach to it. So clearly the patient's not suicidal. He's not shoveling bananas down his gullet repeatedly all day long, so it's probably not something that he's eating. His eating habits have not changed. He's not eating a ton of potassium-rich foods. He's not taking any supplements. He has no history of kidney disease, and he's not on dialysis, so we can kind of cross that one out. No known congenital defects. He's had repeat EKGs in the past. Nothing was ever found. So those things are kind of ruled out. And he takes his medications appropriately. So you try to think that maybe medication toxicity is not it. So he takes all these medications that he's supposed to. So we'll move on here. But wait a second. There's something funny about this list of medications here. And what could you possibly think it is? Pause it, and I want you to pause the video and think about what is wrong with this list of medications in a patient that has hyperkalemia. So go ahead and pause it for a second, and now you're back. And if you take a close look, spironolactone is a potassium-sparing diuretic, and HCTZ is also a potassium-sparing diuretic. Potassium-sparing basically means that they do not, like Lasix, increase the excretion from the body of potassium. So obviously when you're on Lasix, a lot of people have to take a potassium supplement. When you take HCTZ and spironolactone, oftentimes you do not have to take a potassium supplement because they're considered potassium-sparing. Lisinopril is not really a diuretic, it's an ACE inhibitor, but it is also known to increase serum potassium. And beyond that, he takes amiodarone for his atrial fibrillation, and amiodarone prolongs the QT interval. So, perhaps with all this combined, these are likely the root cause of the hyperkalemia. I'll try to get my K, a little plus sign. Okay, there it is. So they're likely the cause of the hyperkalemia. The amiodarone prolongs the QT and could possibly be the result, be the cause of the torsades. It's hard to say what the rhythm was before the torsades, but perhaps between the widening of the QRS, the amiodarone prolonging the QT introduced him into a torsades rhythm, and then subsequently he, developed this bizarre hyperkalemic bradycardia. So the end result was this gentleman was discontinued from these medications. Some of the medications were switched around. He was moved to metoprolol, I think Bumex and Lasix, and he did not have any recurrent episodes of the VTAC, torsades, or hyperkalemic signs after discharge from the hospital. And the last follow-up that was given to us, he was completely fine, following up with his physicians and working on potentially getting into an alcohol program. So initially, we talk about it could have been malnutrition, it could have been many things, but it looked like it is actually his medications, while not at toxic levels of the medications themselves. He was therapeutic for the medications. They were controlling his blood pressure and his heart rate accordingly, but they were also skyrocketing his serum potassium. So his medications were switched around and he was doing quite well. So what are we going to learn from this case today? So the HPI history, they're all extremely important in every case. Don't ever think that you're not going to examine something further because you think you found the answer. You need to get the standard history and exam, the focused exams, all the medications and allergies, the history and the history of present illness carefully examined in every case that you ever contact, no matter what arm of healthcare you're in, whether it's EMT, first responder, paramedic, nurse, nursing assistant, nurse practitioner, physician assistant, physician, surgeon general. Every patient that you come in contact with, these are the standard medical evaluations that need to be very carefully performed in every patient contact that you come across. Also, the emergent stabilization was important in this case. So within 6 or 7 minutes of arriving on the scene, we had cardioverted the patient because it was extremely unstable hemodynamically and wasn't getting any better. And giving a vasoactive drug at the time was not really a good option, so we had to cardiovert. What would have happened if we cardioverted him and he went into his bizarre rhythm and then back into torsades, because that's very common? We likely would have had to give the magnesium anyway, despite him being profoundly hypotensive, because those are really the only two options for that case. So that was very important. For carefully monitoring the EKG and deciding what is likely the cause. What rhythm is it? What is there any signs of ischemia? And what are some of the clinical indicators on the EKG that could point you towards a diagnosis? So careful EKG consideration is an important tool in many more cases in pre-hospital medicine than we would like to let on. So do your EKGs, look at them carefully, and maybe take a second look before you crumple it up and throw it in the garbage and think, man, that James is an idiot. There was nothing on this EKG. Early medical command consult in this case was beneficial because you kept in contact with the physician throughout the whole time, and you had real-time feedback for when you did something and it either worked or didn't work. So having that contact constant and early was beneficial in this case. So that was very good. And constantly evaluate and adapt your treatment plan. If you're not willing to adapt in emergency medicine, you're not cut out for the business. So here we had a patient who was in torsades. You think hypomagnesemia, you treat that, and suddenly you have a completely different presentation of a completely different problem. So, like I said, we'll never know if the patient had low magnesium levels because we weren't able to check it, and we gave the magnesium in conjunction with all the other treatments that we did. But that's always the possibility that that occurred. But if we weren't willing to adapt on this case, we could have hit a stumbling block when we got to that wide sine wave bradycardia with the hyperkalemic signs. If we weren't willing to consider that there was multiple things happening at once. And finally, I'm going to tell you this every video. Learn from every single case that you see. Try to learn something, no matter what it is. Take something home with you, something that you can share with somebody else in this specific case, even if it's the only case you'll ever see that has this one pearl that you're able to take home. Try to take something home from every call. That'll keep you interested, keep you motivated, and most of all, make you a better teacher in the future. So I want to thank you guys very much for taking a few minutes out of your day listening to this lesson on hyperkalemic and going over this case study. Like I said, this was kind of a long one. Most of them will be less than this, but I appreciate you guys spending time out of your day just to watch my EKG case study. So we're going to continue on. Just for a brief message, I want to talk about something that happened to me almost exactly a year ago. I came home from work. I was working night turn last March 27th. Come home from work. I opened up my front door. The first thing I see is that my lovely 60-inch television is gone from my fireplace. The next thing I see is, it's not, you can't really tell very well back here, but this window is completely smashed open in my dining room. That's how the intruders got in. They stole all of my alcohol from my bar rack. They topsy-turvied my whole house upside down. They were in my bed. They were in my kitchen. Every part of my house was basically turned over. And luckily, there was one thing of value that they didn't get away with, and it was my TV in my bedroom. Because of this articulating arm, they were not smart enough to be able to get it off the wall. So, that all being said, I have been authoring an EKG textbook for about 4 years. And when I came home this morning, on March 27th of 2013, both of my computers, my thumb drives and my backup drives were all my external hard drives, and my PC. So 2 laptops, thumb drives, external hard drives for backing up, and my desktop were all stolen. And unfortunately, that had every single EKG that I've ever taken scanned into them, and all the ones that I've gotten from my coworkers and my friends in hospitals. All these EKGs, probably thousands. I would say that I spent hours upon hours scanning these EKGs in to my computer for my EKG textbook, and they are all gone. Not only are they gone, but also the text that I had written was gone, and all the sources as well. So I'm starting over, recreating my EKG book, starting from scratch, obviously, and I have to rebuild my EKG library. And about 3 years ago, my roommate convinced me to throw away my boxes upon boxes of EKGs because I had them scanned in multiple places. They're on my external hard drive, they're on my desktop, they're everywhere. We don't need these boxes of EKGs, and that's probably the only thing that the people would not have stolen would have been my boxes of EKGs. So, unfortunately, starting over, I really need EKGs. So, if you guys could really help me out, I have created a website, and it's called ekgsforjames at gmail.com. And if you have an interesting case, a good rhythm strip, a specific diagnostic EKG, please email me, scan it in, attach it, and email it to ekgsforjames at gmail.com. If you leave information about yourself, like who you are and where you work, you'll get credit for the picture, as long as I use it in either the textbook or in the workbook that's going to come with it. Um, and clearly I'll give you the credit, like I said, and I'll caution you that if you send me a bradycardia, it might not be used in a bradycardic section. It might be used either in the workbook, or it might be used in a different part of the textbook. But I will try to use every valuable EKG that you guys send me, and I will give you all the credit. So if you could please, I'm begging you, go to ekgsforjames at gmail.com and email anything good you have. And it is potential that if I do a podcast that has that topic, that would also use that EKG and give you the credit there. So please consider me if you have an interesting case, any dysrhythmia strips, any good 12 leads from left ventricular hypertrophy to a STEMI to rapid AFib to normal sinus to a bradycardic or an abnormal pediatric EKG, please consider me. Scan it in, send it ekgsforjames at gmail.com. I'm going to put in the documents on Google Docs. I will put in a form that will be on the Word section. And that way, if you are willing to give me, take a couple minutes out of your day, fill it out, and it'll tell me the information about the patient. That way, if I use it in a scenario, I can be as accurate as possible. So I have things like the patient age and gender, the presentation, history, and meds, and just so that I could give an accurate case study if I use it in that capacity. So please, cardiac arrests, any dysrhythmias, like I said, send it to ekgsforjames at gmail.com. I will be forever in debt and always grateful. So until next time, like I said, I appreciate everything you guys have done, spending time out of your day, listening to me babble here at 8:30 in the morning in Pittsburgh, and I would really look forward to hearing from you. And I hope that you not only share me with your friends, but also consider me whenever you have anything good that you want to share. So thank you very much. I greatly appreciate it. Like I said, I hope you have a great rest of your day, and I'll hopefully see you within a month. Thanks a lot.